When an antibiotic tablet is taken, it is absorbed from the gut into the bloodstream, and the serum concentration of the antibiotic rises, as shown by this blue portion of the curve here, before reaching a peak concentration, and then the concentration starts to drop off as the drug is being cleared. This dosing curve repeats after every dose of the antibiotic, such that after 3 to 5 doses you reach what is called a steady state, where the peak and trough concentrations are the same with every dose. The antimicrobial activity of different classes of antibiotics is dependent on different components of the curve. For example, the antimicrobial activity of gentamicin is dependent on its peak concentration over the MIC, or mean inhibitory concentration, which I've represented here by this red dotted line. What this means is that the higher the peak concentration over the MIC, the more effective the antimicrobial activity. This is important because it means that gentamicin must be dosed appropriately at a high enough dose in order to have effective bacterial killing. For treating complicated urinary tract infections, this is at a dose of 5 to 7 milligrams per kilogram. Of course, there will be an upper limit to the dose that you can administer, which is often around 500 milligrams, regardless of weight, because you don't want to give too high a dose where you also increase the risk of toxicity. But the point is, you don't want to give low doses like 3 milligrams per kilogram, because this suboptimal dose is unlikely to be effective. On the other hand, the antimicrobial activity of beta-lactam antibiotics is dependent on the time above the mean inhibitory concentration, or the AUC over MIC, where AUC stands for area under the curve. In this graph here, this would mean that for all of this time where the concentration of the drug, the beta-lactam antibiotic, is above the mean inhibitory concentration, there is antimicrobial activity happening, where there is no antimicrobial activity happening when the drug concentration is below the mean inhibitory concentration, as shown here. What this means is that beta-lactam antibiotics must be dosed at a high enough dose and frequently enough to be able to have a concentration that is more or less always above the MIC in order to effectively kill bacteria. This is important in situations like when you're using piperacillin tazobactam to treat Pseudomonas, where 6-hourly dosing is more effective than 8-hourly dosing at covering Pseudomonas, where 8-hourly dosing is probably suboptimal. It is also why, for example, in severe infections such as Staph aureus bacteremia complicated by infective endocarditis, flucloxacillin may have to be dosed up to 4-hourly as opposed to the standard 6-hourly in order to achieve effective bacterial killing in this situation. Most antibiotics available in an oral formulation have good bioavailability, with the exception of vancomycin, as we've discussed. Some antibiotics, like amoxicillin and clavulanic acid, or trimethoprim, or clindamycin, and even metronidazole, have very high bioavailabilities, around 90% or more, which makes them very effective as oral options. Of course, giving intravenous antibiotics will allow essentially 100% bioavailability, which will lead to a higher blood concentration of the antibiotic and theoretically more antimicrobial activity. And so in severe or deep-seated infections where you need to get a high concentration of antibiotic in the blood, intravenous antibiotics are usually given initially, before stepping down to oral antibiotics when the patient has substantially recovered. Most antibiotics have recommended doses, which will vary depending on the infection that is being treated and the need to achieve higher blood concentrations of the drug. For example, amoxicillin needs to be dosed at 1 gram 3 times a day when treating pneumonia, because you need to achieve a high blood concentration in order to have adequate lung penetration to adequately treat pneumonia. In contrast, when amoxicillin is used to treat urinary tract infections, it only needs a dose of 500 milligrams 3 times a day. The overarching idea is that you want to achieve a high blood concentration of the antibiotic early on in the infection, because that's when you have the highest bacterial load, and this is most easily done by using intravenous antibiotics in severe or deep-seated infections. In milder infections, having a lower blood concentration, which can be still achieved by using oral antibiotics, may be adequate. Giving antibiotics orally is going to have a less bioavailability than giving the equivalent antibiotic intravenously if possible, because intravenous antibiotics will achieve 100% bioavailability, where oral antibiotics will usually have less than 100% bioavailability, although will still be quite high and adequate. Oral antibiotics can often cause significant gastrointestinal side effects such as nausea and vomiting, and this often limits the total dose that can be administered orally, especially in a single dose. So now, to put it all together, I just want to go through an approach to antibiotics and some important principles. The empirical antibiotic choice is going to be determined by the source of the infection, which you think is most likely. Sometimes this can be difficult, and when the source is unclear, the recommended regimen where I work in Australia is that of flucloxacillin and gentamicin, where flucloxacillin will obviously cover the gram-positive cocci from skin sources, which are a common cause of infection, whereas gentamicin will cover essentially all the gram-negative organisms, which commonly cause urinary tract infections and intra-abdominal infections, including organisms like Pseudomonas and to some extent ESBL as well. But personally, I try my best not to use this sort of regimen, because I often believe that if the patient does have an infection source, if you look hard enough, you should be able to find that source of infection. And the antibiotic regimen should be tailored towards the suspected source of infection. It is also important to keep an open mind and a wide differential diagnosis for the causes of a fever, especially in the absence of truly any localizing signs of infection, because things like autoimmune disease flares and malignancies can also present very similarly to sepsis. And in these situations, giving antibiotics would not be of any benefit unless there is an infection that has triggered the autoimmune flare, which is not an uncommon situation to see. But once a source of infection has been identified or suspected and an empirical antibiotic regimen is chosen, it is important to understand what is being covered by those antibiotics that you're prescribing, and more importantly, understand what is not being covered. For example, when you prescribe someone augmentin or amoxicillin clavulanic acid, it's good to understand that this has reasonably good gram-positive cover, gram-negative cover, and anaerobic cover, but it doesn't cover organisms like Pseudomonas or ESBL. And so, in this situation, if Pseudomonas is suspected, then giving something like piperacillin tazobactam may be a more appropriate option. And if ESBL is suspected, then giving meropenem may be a more appropriate empirical option. As another example, if a patient is given amoxicillin for treatment of a community-acquired pneumonia and doesn't improve after completing the treatment course, one needs to re-evaluate the diagnosis and consider other organisms that may not be covered by the particular antibiotics that are being given. So in the case of a patient who has a community-acquired pneumonia who is not responding to amoxicillin, one needs to consider that they may have a Haemophilus influenzae that is producing a beta-lactamase which confers resistance to amoxicillin, or that the pneumonia may be secondary to an organism such as Moraxella catarrhalis, for which amoxicillin would not be able to cover. In such a situation, escalating the antibiotics to ceftriaxone may be useful because it would be able to cover both of those organisms mentioned. In contrast, escalating to intravenous benzalpenicillin may not be useful in this situation because it still would not cover Moraxella, and it probably will not cover the beta-lactamase producing Haemophilus either. Another major principle is to always try and go from broad to narrow in terms of your antibiotic coverage, and to always try to go from intravenous to oral antibiotics when treating acute infections. For example, if a patient with a community-acquired pneumonia responds well to intravenous benzalpenicillin therapy, then you can confidently step down to oral amoxicillin to complete the treatment course, because amoxicillin and benzalpenicillin have very similar coverages. This also holds true for antibiotic pairs such as intravenous ceftriaxone and oral cefuroxime. You want to try and avoid going from narrow to broad if they're already responding to the narrow spectrum antibiotics, because by unnecessarily broadening antibiotic coverage, you are unnecessarily providing a broader than needed antibiotic drug pressure, which can then, in the long term, lead to the formation of multi-resistant organisms, as it promotes antimicrobial resistance. This is why antimicrobial stewardship is very important in modern medicine, and we must try and prescribe antibiotics appropriately to try and preserve the use of our broad-spectrum, high-end antibiotics for as long as possible. Going back to that example of the patient with the pneumonia who has responded to benzalpenicillin, stepping down this patient to augmentin or amoxicillin clavulanic acid does go from the intravenous to the oral route, but is actually going from a narrow to a broader spectrum antibiotic in augmentin, which would be unnecessarily broadening antibiotic coverage. As we've discussed, you need to pick an appropriate dose, frequency, and treatment duration, which will be determined by the infection source and severity. Many guidelines exist which will guide the duration of therapy, but it's important to always tailor your duration of therapy to the treatment response. For example, if you've completed the guideline-based treatment duration and the patient still has elevated inflammatory markers and still is symptomatic from the infection, then chances are either the treatment was inadequate or the diagnosis was inaccurate, in which case this has to be re-evaluated. For infections like pyelonephritis, if the patient responds really well after 10 days of treatment, that is usually adequate and treatment can be stopped then. Otherwise, treatment should be extended to 14 days and re-evaluated at that point. Chronic infections like cellulitis and osteomyelitis need ongoing monitoring of infection markers to guide the need for ongoing treatment, which may end up being weeks, months, years, and even lifelong. There are lots of different parameters that you can look at to help you determine if the patient has had a good treatment response or not, and that can help guide when to switch from intravenous to oral antibiotics and when you can stop antibiotics. Personally, I use a combination of things, including clinical improvement, namely if the patient feels that their presenting symptoms have improved with antibiotic therapy, as well as objective markers such as a closing or decreasing neutrophil lymphocyte ratio, as well as being afebrile for at least 24 hours, because ongoing fevers for more than 48 hours after starting intravenous antibiotics may be a sign that the antibiotics are not effectively treating the infection, or that this is not even an infection at all. I often don't use CRP as a marker to step down for intravenous to oral antibiotics, because CRP often lags as part of the inflammatory response to infection. This is discussed in more detail in another previous video titled Understanding the Inflammatory Response to Infection, which might be good to have a look at if you haven't already. Another important point is to be aware of the antibiotic side effects, which can help guide which antibiotics to prescribe. For example, when I'm trying to decide whether to give doxycycline or azithromycin as a typical cover for a patient with community-acquired pneumonia, I would usually give doxycycline unless I think that the patient has Legionella or Mycobacterium avium complex, in which case I would need to give azithromycin. But doxycycline can produce quite significant esophagitis, and so if the patient has severe reflux symptoms, then doxycycline may not be a good choice for this particular patient, and I would go with azithromycin instead. However, if the patient had a long QT or was on another QT prolonging drug, or had underlying structural heart disease, then I'll be less inclined to give azithromycin in that situation to avoid any complications that can arise from this. But say if the patient had an asthma exacerbation as well as a pneumonia, then azithromycin may be more beneficial than doxycycline in that it has some anti-inflammatory effects. So there are numerous risks and benefits of every medication that you prescribe that has to be taken into account when you make your final decision of what antibiotics you're going to go for. And lastly, it is always very important to try and get source control of the infection, because treating with antibiotics may be able to reduce the bacterial load, but as long as there is still a site for bacteria to seed, such as biofilms, elimination of the bacteria may not be possible. Similarly, we should try and identify underlying risk factors for patients who have recurrent infection and try and manage these in order to minimize the risk of infection. For example, patients who have an indwelling catheter or peripheral or central lines may become infected, and in that situation, the infected catheter should be removed. In males with recurrent urinary tract infections, structural abnormalities in the urinary tract, particularly benign prostatic hyperplasia, should be investigated for and managed to prevent urinary retention and stasis as the basis for infection. If the patient has an abscess or an infected collection, drainage of this is often required for diagnostic and therapeutic purposes, and surgery may be required to obtain source control of infected organs. So in summary, this is an approach to antibiotics with some important principles which hopefully you'll find useful and can incorporate into your practice. And that brings us to the end of this video. I hope you now have a better understanding of antibiotics in terms of the underlying pathophysiology and the clinical application. Here is a slide of the key take-home messages that we've discussed throughout this video for your review. If you like this content, please leave a like, comment, and subscribe to the channel. All the best.